radiation exposure, how it's delivered, can determine whether or not there's going to be any type of cell recovery in between these exposures. So the concept that we're going to be talking about here is protraction and fractionation. It says here, if the dose is delivered in a longer period of time rather than quickly, the effects of those doses is less. Time is allowed for cell repair and recovery in between. So the lengthening of time for the delivery of doses can be accomplished in two ways. This is going to be protraction and fractionation. And actually, when I was looking over the slides, there is a huge typo on this, a huge typo, okay? When you look at protraction, it should say dose is delivered continuously at lower doses, not higher doses, it should say lower doses, so fix that. Oh, I'm going to fix it on mine too. Okay. So the dose is delivered, the cumulative dose is delivered continuously longer at a lower dose rate. So the example that I have here is 2 grays per minute for 3 minutes, okay, equals 6 grays. That's protraction, okay? So the dose is delivered continuously at a lower dose. Or what I could do now is I can take that same cumulative dose and break it down into 12 different sessions. So the same cumulative dose broken up into 12 sessions will be, instead of 2, it's going to be 0.5 times 12 treatments and still going to equal the same. Does this sound familiar to you guys? Is this related? Is this kind of like figuring out MA in time? Right? MA in time. We're talking about the delivery of the dose. Doesn't matter how you deliver it. You can either do a short time or long time. As long as you adjust the other one, the cumulative dose is going to remain the same. This is the same concept that they do for radiation therapy, okay, radiation oncology, when they're treating their patients with a tumor, blasting them with high doses of radiation, okay? Because if you blasted that patient, if you gave them, let's say, six grays at one time, their body's not going to be able to handle that. Okay? Whereas if you deliver it in stages, like what most radiation therapy treatments are, when you go in for a treatment, you are there for 5 days straight. But in between those treatments, you have a break, and your body gets a chance to recover. When you're having radiation therapy, not only are you killing cancer cells, but you're also killing what? Good, healthy cells. So we want those healthy cells to recover. All right? At the same time, we're trying to treat the cancer. So this is where it comes in. Protraction, low doses, continuously. Okay? Or the same amount of dose, but broken up into different sessions, different treatments. It's the same cumulative dose.
So which one's better?
It depends on what they're treating. Depends on what they're treating. So if you're having to deal with somebody, if you're dealing with maybe a small tumor, this may be okay. Okay, because you're not going to cause a lot of collateral damage. But if you're using a very high dose, okay, you may want to break it up in sessions because the body may not be able to handle that dose, and they can experience, remember that acute syndrome we were talking about? Okay, they may experience a lot of vomiting and diarrhea and dehydration immediately after the treatment. And you kind of do see that when somebody's having radiation treatment. They get nauseous, they're weak, right? They're very pale because you've also killed some of their healthy blood cells, so they're pale. So if they're getting a big dose, you may want to split it up, like we have here in fractionation. So it depends on what you're treating.
Is it always with just gamma radiation, or is it different?
They use different types. Yeah, they use different types. With radiation therapy, they use gamma. They also use X-rays of megavolts. Okay. Other factors includes the oxygen effect. This is also used in radiation oncology. They have found out that tissue is more radiosensitive when it is oxygenated rather than anaerobic. Oh, oxygenated and aerobic than when it's anaerobic, anoxic. Throwing terms out there, with a master. Tissue is more radiosensitive when it is oxygenated or aerobic. Okay, this oxygen effect, or OER, oxygen effect response, is a mathematical description when a tissue is given plenty of oxygen. Radiation therapy is done in conjunction with a hyperbaric oxygen chamber. This is a high pressure chamber. And so this is what it says. Oxygen increases the effect of low LET energy. So now when we can use lower energy, low LET radiation, okay, to kill cancer cells without having to use high energy type of radiation. Is that good for the body?
Mm-hmm.
Okay, so now we can use lower doses of radiation and have the same effects as if we were using higher energies by introducing oxygen to that particular tissue that we're trying to treat. Okay? Fully oxygenated cells have a radiosensitivity 2.5 to 3 times that of an anoxic cell. A fully oxygenated cell has a radiosensitivity 2.5 to 3 times that of an anoxic or hypoxic cell. Which means, based on what we just covered with RBEs, remember in our previous slide, the RBE for an X-ray, regular diagnostic X-ray, is 1. Okay? If we introduce oxygen to the cell that we're trying to treat, the RBE now is increased to 3. In other words, now we can cause more damage to that cancer cell if we introduce oxygen using the same type of X-ray. Yes?
How do you make it like the area more oxygenated?
How do we put them in a hyperbaric chamber? It's basically, it's a chamber, high pressure, and we're infusing heavy concentration of oxygen through their skin. We can also aerate it through just regular oxygen just they're intaking.
But doesn't that increase the oxygen in the body?
Yes, it does. But when we're doing radiation treatment, you're not irradiating the whole body, you're just irradiating just that certain area with radiation. So although the oxygen is going throughout the body, you're only focusing on one part of the body. Okay? Now this is what happens. Remember we're talking about free radicals. Remember free radicals when you split 2 molecules? Okay, you're splitting 2 molecules, so you have an H radical and you have an O radical. What we're doing here is when we're introducing oxygen, we're actually increasing the number of oxygen molecules in the body. So when it gets struck with radiation, those molecules, oxygen molecules, split up into smaller molecules, which are very unstable, resulting in free radical oxygen. What did we say about free radicals? Do they have excess energy?
Yes.
So this is what's happening. So not only is the radiation trying to kill the cancer cells, now the free radicals that we form in the body with the oxygen is also now doing its part by killing any of the cancer cells that it's surrounded by. That oxygen radical, that O radical, is releasing excess energy to kill the cancerous cell as well. So that's what happens. So again, the RBE for just diagnostic X-ray no oxygen is 1. But once we introduce oxygen into that area to be treated, it now increases by 3 times. Does that make sense? Okay. Other factors. Age. Your body's more sensitive before birth and at a young age, and as you mature, this goes hand in hand with the development of your cells, right? So you're more sensitive at birth at a young age. They are less sensitive as you mature, but then again, they become more sensitive again as you get older. Okay. Why? Why does it happen here when you get older?
Because your cells are not.
Exactly, because you're no longer reproducing those cells. So if you kill those cells, they're not coming back.
Or not as quickly.
Well, not as quickly, or some of them may not come back. Yeah. You guys are on it. Okay. Recovery. If cells repair themselves and recover before they begin to replicate in prophase, they can't replicate. If they shrink or become atrophic during interphase, this is known as interphase death. So if they shrink or become atrophic during interphase, this is known as interphase death. And if a sufficient number of cells sustain minimal damage and survive, repopulation can occur. So there is hope. Other factors that influence radiation exposure is the use of chemicals. You've got 2 different types of chemicals. You've got radiosensitizers, which enhances the effect of radiation, like vitamin K. Okay, so when vitamin K is injected systemically, your body becomes more sensitive to radiation, so you don't have to use as much radiation. Whereas you have radioprotectors, which decreases the effects of radiation. Now here is the caveat. To be effective, it must be given at a lethal dose. The effects then would be worse than radiation. So there are no human applications for radioprotectors. Right. Okay. Hormesis. Hormesis. Sounds like a can of spam. Hormesis. Okay, hormesis is the belief that a small amount of radiation can actually be good for you. Example, a little fluoride is healthy, but at large amounts it can be deadly, right? Just like anything else. Okay? In small doses it's good, but if you have too much of a good thing, it's not a good thing. Okay, so what they say with hormesis is that it stimulates hormonal and the immune response. It has been shown in lab animals that when exposed to certain doses of radiation, they have lived longer. But even then, what are we going to practice? We're going to practice ALARA. And ALARA says, as low as reasonably achievable, no matter how large the dose is or how little the dose is, it's going to cause some type of biological effect. That is our guard. That is our protection. We're not going to take any chances, regardless of how small, how little. It is going to cause some type of biological effect. Okay. Even though we know that there are cells and tissues that are more radio resistant, but are we going to take that chance? No, you're still going to practice good radiation protection. Time, distance,
Shielding.
Okay. Okay, so what we're going to talk about now here, I think we're almost done, right? Is the dose-response relationship graph. The dose relationship graph. How your body responds to certain doses. It can be described graphically in 2 ways. You have the linear or non-linear, and is the graph straight or curved? So I put up a few examples here in how this looks. Okay, so the first one here This is zero dose right here, right? This is zero dose, and then this is increased dose. Zero effects with its increased response. Okay? So a normal graph would show like this. As dose increases, so does the damage or the effect, and it is proportional. A straight line says it's proportional. So with increased dose, so is the resulting effect. Okay? Now, if it's linear non-threshold, it says here, no matter how small the amount, it's going to be what? There will be
Effect.
some type of effect. Now, when you look at C and D, this is linear threshold. So linear threshold says, well, as long as I'm within a certain dose, there isn't going to be any damage. It's not until I hit that threshold where there will be damage, and as it increases, more damage will occur. Okay? This is what we follow, B. But in studies, we do know that there are certain cells that are radiosensitive to a certain point, and once you reach the threshold, then damage occurs. Agree? Now, A is usually done in a general population where they're saying here that this effect was not a result of radiation. Okay? Like when they're studying leukemia, they're going to say, well, maybe it's not caused by radiation, maybe it's caused by the electrical power lines near your house. So, A then is a normal response without radiation exposure. Okay, any questions here? Yes.
So which one's worse?
Which one's worse?
Yeah.
It depends on what you're referring to. We follow this as a guideline. So again, and I don't care how much exposure you're going to get, I'm going to protect myself, because what this says here is no matter how little, there's going to be some damage. These are just graphs that demonstrate the different types of studies that they do based on tissue and based on cells. Because when you're looking at C and D, we know that, for example, when you're talking about like erythroblasts, okay, red blood forming cells, this is what's going to happen. They're going to be sensitive at very low doses. Stem cells, immature cells. But if you're talking about like muscle and nerve cells, they're more radiosensitive. So nothing happens with this dose, and it's not until you hit the threshold that they become affected by it and they are destroyed, or have some damage. Okay, so this can refer to your intermediate cells, intermediate radiosensitivity, and this can refer to radio-resistant cells. Does that make sense? Okay. All right, so the next one here is your non-linear. Non-linear. Very similar to that of linear. Okay. A, no threshold, right? Because as soon as you increase your dosage, there is an immediate response. An immediate response. But it's also showing here that as your dose increases, the response decreases a little bit. It's more sensitive at lower ranges. Yes? B is another one here where it is responsive, also non-threshold. It starts to respond with a little dose, just a little bit as you increase the dose, but it's not until here that it is more sensitive. And then here you've got non-linear threshold, but it doesn't occur until you hit a certain dose. As long as you stay within that dose, it's considered safe. Okay, so low response here. It's not until you get here that you have a high response. And then when you get around here, it starts to shoulder off. The response isn't as great. It starts to taper off. That's all that means. Okay? Any questions? Are we done?
I think so.
So generally, this is how it's going to happen. So today is going to be a short day because all I'm doing is a lecture. But from this point on, you're gonna take a test, and we do a lecture, and it's gonna take up the entire class time. The next thing after that is gonna be test and lecture, so it's gonna be a little bit longer. We'll take up the entire class time. Today we won't. You got it?
Mhm.
All right, guys, we'll see you next week.